Today we're going to focus on the vascular physical exam. Keep in mind that patients with peripheral vascular disease may have systemic manifestations, and therefore it's very important to look at the entire body for evidence of vascular disorders. As with any physical exam, you first begin with the vital signs. With the vascular physical exam, one must focus on the fact that patients with vascular disease may have, for instance, renal artery hypertension, and as such, it's important to carefully check the blood pressure. Also, one must remember that patients with vascular disease may have obstruction in their subclavian arteries, and as such, I recommend that blood pressure be taken in both arms. Once we finish checking the vital signs, what we should do is to check the pulses. Remember that with the pulse exam, there are 17 pulses that you should check. We begin in the head and check for the superficial temporal pulses. Next, we check the pulses in the common carotid. When you feel here, you're actually palpating the common carotid and not the internal or the external carotid. So the absence of a pulse here signifies that the common carotid is occluded. When we grade the pulses, we grade the pulses from 0 to 2, with 2 being normal, 1 diminished, and 0 absent. From the neck, we go on down to the arm, and in the arm, we check the radial pulse, and we check the brachial pulse in each extremity. And when I feel the pulses, I usually use my index and middle finger, and I use this part of the finger. If I use the flat part of the finger, there's a tendency sometimes to feel one's own pulse. And if you're not sure, particularly when you're doing the foot pulse, what you should do is check the patient's pulse and at the same time check your own pulse to make sure that the two aren't in sync. Then we have the patient lie down, and as part of the vascular exam, and I won't go into the details here, one should listen to the heart and the lungs. Listening to the lungs may indicate evidence of heart failure. Listening to the heart, you may pick up on arrhythmias, which may be a source of emboli. You also may pick up murmurs or evidence of aortic stenosis, which would be an important risk factor if a patient needs any type of vascular surgery. When we listen to the heart, we should also, at the same time, listen to the carotids for bruits. When you hear a sound that appears to be a bruit in the neck, go down to the heart and make sure that it's not a transmitted murmur. What I typically say to a medical student is that if I hear a murmur here and hear a bruit here, I try to decide where it's louder. If it's louder in the neck, it's more likely a carotid bruit. If it's louder down here, it's more likely a murmur from the heart. We then proceed to the abdominal exam, and on the abdominal exam, you first listen for a bruit, and I usually use the diaphragm part of the stethoscope. And when I listen for a bruit, I listen in the midline and also listen to each side. If you hear a bruit in the abdomen, it signifies turbulent flow. This could be either a stenosis in the renal artery, in one of the mesenteric arteries, in the aorta itself, or in the iliac arteries. It could also signify potentially turbulent flow from a aortic aneurysm. Then a very important part of the vascular physical, which is often omitted by the standard practitioner, is to feel for an aortic aneurysm. And the way I recommend to do that is to put one finger here and one finger here in this manner, and gently push down until you feel the aortic pulse. And once you feel the aortic pulse, you slowly move your fingers apart to the point where you can no longer feel the pulsation. And once you have done that, you roughly measure the distance or the width of the aorta. The normal aorta, of course, is 2 centimeters, and so anything beyond that should raise suspicion. In a patient who is obese, you may not be able to feel the aortic pulse, but it takes a little extra time to feel it, and you have to push fairly deep, but go slowly. We then proceed down to the femoral pulses. To feel the femoral pulse, remember that the inguinal ligament can be found by putting one finger on the anterior superior iliac spine and one finger on the pubic tubercle, and around halfway in between, perhaps a little bit more medial than halfway, you'll feel the femoral pulse. And again, this should be graded from 0 to 2. Likewise, you should listen over both femoral arteries for a bruit. And again, I use the diaphragm side. If you hear a bruit over the femoral artery, it again indicates turbulent flow and would suggest a stenosis either in the femoral artery or in the iliac artery above. Keep in mind that if this pulse is diminished, it indicates that there's a blockage in the iliac artery above. If this pulse is absent, it indicates that the iliac artery on that side is actually occluded. Another point that I didn't mention up here is that in addition to feeling the pulses here, you should listen for bruits just above and below the clavicle on each side. Because if you hear a bruit there, it suggests a possible subclavian stenosis. And that would then be supported by the finding of a difference in the blood pressure in each arm and a reduction in the pulse exam on one arm. Remember that subclavian artery stenosis is more common on the left. And this should then prompt you to ask the patient questions regarding subclavian steal syndrome, which would be exercise-induced tiredness in the left arm, and at the same time the development of vertebrobasilar symptoms such as dizziness, drop attacks, or vertigo. We then proceed down to the leg exam. And in a patient who might be complaining of claudication, we inspect the leg and look for evidence of peripheral vascular disease. The things that we specifically look at are, number one, the tone of the legs. Does it appear that there is loss of tone and muscle atrophy? We look at the hair pattern. Remember, in a patient who has diminished blood flow to the extremities, the hair follicles will have died, and the patient will often lose the hair down over the tibia. In addition to that, the sweat glands are damaged, and the patient's skin will thus become very dry and scaly. We also inspect the nails, the nail beds. The nails may be thickened and dry and scaly. We also look for evidence of ulceration. Ulcerations on the medial aspect of the leg are indicative of venous insufficiency, as also termed venous stasis ulcers. Such a patient would also often have edema of the leg, hyperpigmentation, and varicose veins. We look at the foot for evidence of ulceration at the tips of the toes. Ulcerations here are typical of patients who have arterial insufficiency and are also indicative of a diabetic foot ulcer. We also need to look between the toes because sometimes a patient can develop ulcerations at pressure points between the toes that are the result, again, of peripheral vascular disease. And then we look at the bottom of the foot. On the bottom of the foot, we look for evidence of ulcers over prominent points, such as the first or second metatarsal. Ulcerations in this area are considered generally to be neuropathic ulcers because they are over pressure points. And this is most commonly seen in diabetic patients. But keep in mind that patients who have diabetes may also have arterial insufficiency, so ulcerations here could be the result of both arterial insufficiency and neuropathy. As part of the exam also, one should do a motor and sensory exam and see if the patient has evidence of diminished sensation. One good way to do that is two-point discrimination. As far as the pulse exam and the popliteal, this is one of the most difficult pulses to feel for medical students and physicians alike. What I recommend is to put both fingers behind the popliteal fossa in this fashion and the thumbs anteriorly and have the patient completely relax their leg. So I put my hands underneath with my thumbs here, and typically I need to go a little bit more lateral than I think I need to, and typically also you have to press much harder than you think you need to. Again, fingers like this in the back pushing hard, and then you move back and forth until you can identify that pulse. And as I said, sometimes you need to go more laterally and a little more inferiorly. What I typically tell medical students is that if the pulse feels very prominent and easy to feel, you should suspect that the patient might have a popliteal aneurysm. Remember that popliteal aneurysms, when present, are bilateral in 50% of cases. And if a patient has a popliteal aneurysm, there's about a 30% chance of an aortic aneurysm. We then go down to feeling the dorsalis pedis pulse. And to tell students, the best way to remember how to feel that is you find the extensor hallucis longus tendon and then go a little bit lateral to that, again using your two fingers. And then we feel the posterior tibial pulse with the same fingers right by the medial malleolus. So remember, there are 17 pulses that you should feel on the vascular physical exam. 2 superficial temporal, 2 carotid, 2 radial, 2 brachial, 1 aortic, 2 femoral, 2 popliteal, 2 dorsalis pedis, and 2 posterior tibial. And remember again that vascular disease tends to be systemic. If a patient comes in with evidence of claudication with peripheral vascular disease in the leg, chances are that they may have aortic or renal or mesenteric disease, subclavian disease, or carotid disease, as well as coronary disease. And so you need to focus on those aspects of the physical exam as well.